Okay, so we reached up to block 3 of NBME 20. So far, it's been a pretty nice ride. We really have seen a couple questions that popped up that were the same topic being asked about in different ways so far. Uh, we also got to see how a lot of questions like this one we have in front of us right now, a lot of questions that are really, really big are often questions that were really easy to begin with, but then the length of the question started making it slightly more confusing, right? Because as a test writer, your job is always to make sure you have a sentence in there for the correct answer choice, which in this question is E. Then you need to have sentences in your question that can somehow relate to each one of the other wrong answer choices. And this question is actually very relatable to what we've been doing recently, right? Right now, I did a stream earlier today too, and we just recently finished neurodegenerative disorders. So this is a question on this chapter of neurodegenerative disorders. And, what you want to make sure you do is you're able to correctly cancel out answer choices by realizing that nothing in the question gives away the main defining factors, of these answer choices that are either right or wrong. It doesn't matter which one you really do first. Either is fine. Just make sure you do them, I guess. Everyone does like 18 and onwards, so 18, 19, 20, 21, 22, and 23. You can pick any of these and just do them. What I've been noticing in my time revising these last few NBMEs, 20 and onward, is that a lot of questions tend to pop up over and over in the various NBMEs. Like the same question is going to be in multiple NBMEs, and it might just be the different answer or a different presentation of the same topic. So by doing so, you do definitely prepare yourself for an NBME if your school requires it. That's definitely something. But other than that, you get to learn. You get to learn how different topics can present and how you could change a question stem up to make the answer not be E anymore, but maybe be B or A, something like that. So let's take a look at this now. We can get started. Number 1, so block 3. A 50-year-old man is brought to the physician by his wife because of personality changes for 2 years and cognitive decline for 3 months. His wife says he used to be such a kind and shy man, but now he screams at strangers for no apparent reason. The other day, he yelled at a woman at a convenience store for not ordering extra cheese in her sandwich. He said she needed the extra calcium. She adds, this has been going on for a while, but last month he almost invested all of our savings in a startup company that was going to produce different kinds of hats strictly for dogs. He was never like this before. He was a respected accountant. I stopped him, thank goodness, and it turned out to be a scam anyway. She adds, I'm worried about his physical safety too because I've had to search for him 5 times within the past couple of months after he got lost wandering around our neighborhood. We have lived there for 20 years, so there's really no reason he shouldn't have known his neighborhood well. Neurologic exam shows a palmomental reflex and hyperreflexia throughout the upper and lower extremities. His mood appears normal except for occasional inappropriate cursing at the physician. His mini mental state exam is 21 out of 30. A CT scan of the head shows disproportionate atrophy of the frontal lobes bilaterally. Which of the following is the most likely diagnosis? So, looking at everything they gave you, the majority of this question stem was just quotes of what the wife is saying. And this is a very realistic presentation. Oftentimes, when a spouse comes with the patient, the spouse will be the one describing everything, and they're so fed up and tired of it all, they end up talking a lot more than they needed to. So from the things they gave you, though, it's very obvious this is frontotemporal dementia. Answer choice A, dementia, Alzheimer type, would be wrong because he's not doing just Alzheimer things. Remember that in Alzheimer, you're not going to have weird behavior per se. Alzheimer is strictly just loss of memory. That's all that's going to happen. Majority of the question is going to be about memory, and the patient would tend to be a little older than this, maybe in their 60s. Huntington disease was not relevant at all in this question, right? There's no Huntington or Parkinson related stuff happening in these questions for the most part. Vascular dementia is usually due to multiple infarcts that can be due to like various traumas that a patient might have gone through. But this is very evidently PIC disease. Frontotemporal dementia, also known as PIC disease formerly, is early changes in personality and behavior, or aphasia may have associated movement disorders. While this presents very similarly to Huntington's, you can differentiate it because in this item it says atrophy of the frontal lobes bilaterally, whereas Huntington has atrophy of the caudate and putamen with ex-vacuoventriculomegaly. And you should really be able to differentiate between all these neurodegenerative disorders very well. We've been doing this in the more recent videos for a while now. And, pig disease or frontotemporal dementia is really going to be emphasizing a lot about the behavioral changes like that question did. And, everything else is going to be secondary to that. The only thing I was mentioning earlier when I did the stream for neurology was that frontotemporal dementia has these hyperphosphorylated tau proteins, which are the same hyperphosphorylated tau proteins you kind of tend to see in Alzheimer. Right? So Alzheimer also has the same hyperphosphorylated tau protein. And when I did the video, I think 2 neurology videos ago, about neurodegenerative disorders, we saw where the tau proteins came from. They were part of the cytoskeletal element, and when all of them kind of rip off the cytoskeletal element, the cytoskeletal elements break, and all the tau proteins kind of stick to each other, making neurofibrillary tangles. So that's kind of where that was coming from. Other than that, the question stem didn't fit anything else, so you really couldn't pick any of these other guys. And vascular dementia is a result of multiple arterial infarcts or chronic ischemia. Right? But it's not going to be something where you're going to really emphasize characteristic changes. Alright, this was a pretty interesting question, kind of lame too, because we don't really tend to know this anatomy very well. So, a 72-year-old woman with dysphagia is undergoing surgical evaluation of a mass in the posterior mediastinum, so she's really old. During this procedure, the thoracic duct is inadvertently damaged near the mass, so the mass is in the posterior mediastinum. So they damaged the thoracic duct somewhere in the posterior mediastinum. The injury is most likely to impair the normal lymphatic return of which of the following structures? So if you look at your lymphatic duct, right? Let me make this bigger. If you look at your lymphatic duct, you have your cisterna chyli down here. Around the T12 vertebra, it starts going upwards as a thoracic duct. You have your T5 vertebra where it kind of starts reaching the final place of drainage, and it reaches your left subclavian vein. Right, so around the T5 vertebra is where it finally reached your behind the mediastinum area, right, around the T5 vertebra. So now at this point where you have your supravian cava, you have your heart, you have your esophagus, this area here between T5 and C7 is kind of where you have your mediastinum. So right here, we're saying we may have cut it off right here. So you start looking at your answer choices. You have the heart, the left breast, left upper extremity, right kidney, right lung. There's actually, remember earlier I was saying that a lot of questions can be answered by hardcore logistics majors, even if they don't know medicine, right? Because you have logical questions like which one of these is different from the other. So if you look at all of these answer choices, the one that really sticks out compared to the others is the right kidney. Not only is it one of the major guys of the sad pucker, but it's also the only guy below the diaphragm, right? Below the diaphragm. So your right kidney is actually further down over here, and that was the answer, right? The left upper extremity and breast are drained by the axillary lymph node, which would make it fine to this area. They wouldn't that drainage would not be impeded. The kidney is drained by the thoracic duct. The heart has its own lymph system going on surrounding the heart, so that couldn't possibly be the answer. Everything ultimately needs to reach the supravian cava through the left subclavian vein. And if you cut it off right here somewhere, then anything coming up from down here won't be drained, and that would be your right kidney from these answer choices. Okay, so definitely a question that could, be wrong. Someone can get it wrong. It's definitely a question a lot of people can mess up, but you really need to know the anatomy of your thoracic duct very well, because lymphatics is a pretty big question. Right, so I put it into my book too, and both of these images do a pretty nice job showing you, how everything gets drained, ultimately coming back to your subclavians and going into your inferior vena cava. Right, so the book has lymphatic drainage associations, but it doesn't really break down lymphatic drainage that well. So I've spoken about this a lot in my immunology videos, because there are a couple questions you can get on lymphatics that can be slightly difficult if you don't know what you're talking about. And this was an example of one of those things. So this is a very nice image to really understand how number 2 works. Number 3, a 26-year-old man undergoes an abdominal exploratory operation after sustaining a stab wound in the left upper quadrant. He is found to have laceration of the fundus of the stomach. During mobilization and repair of the stomach, he develops heavy bleeding due to damage to one of the short gastric arteries. The short gastric arteries branch from which of the following arteries? Now, you really need to know the anatomy. Oh, you need to know everything. But the anatomy of the stomach, remember I was saying, I think in block 1, that I feel like GIT is definitely one of the easiest organ systems of step 1. You just need to know your things pretty well, but other than that, nothing is very complicated or confusing. Here the answer is E. It's part of the splenic artery. Remember that the splenic artery goes behind the stomach, supplies the spleen, and then it has a short gastric artery that goes to the fundus. Right? Branches of the celiac trunk are the left gastric, common hepatic, and splenic. The splenic gives the short gastric up for the fundus, and the left gastroepiploic for the left greater curvature of the stomach. And if we go back and take a look at that, if you've revisited this like maybe 3-4 times, you will master this really quickly. The rest of the arterial supply for the supreme mesenteric and inferior mesenteric is actually very straightforward and easy. There's nothing confusing there. Here it's just a little extra information, but you have to break it down like this and you have to study it, and you really have to make sure you have this image drilled into your mind, because in GIT you can get questions regarding ulcers, you can get questions regarding perforations, and any of those things can actually injure these arterial supplies, causing hemorrhage. Right? And this kind of hemorrhage in here is often really not something you can stop, so the person will bleed out to death, and that will be really, really unfortunate. You also get questions about pancreatitis that can also injure any of these blood vessels, and that's also another reason it's significant. So you want to make sure you know the branches just the way they are listed right here. Okay, so you can see your short gastric, your left gastroepiploic, all coming off your splenic artery. Right? This one right here, the left gastric, literally just gives you your esophageal branches and the shorter curvature. Right? So the artery for the shorter curvature, and that's it. And then the right gastric has right here, the other half the shorter curvature. Everything else mainly comes off of the common hepatic, which has things for the hepatic, the pancreatic duodenal, and the greater, or the right side parts of the stomach, and that's it. The color coding here is pretty good too, so that also helps. 2019 did a good job. Number 4, this question was a little confusing for some people. So really dry. Okay. A 56-year-old man comes to the physician because of a 6-month history of worsening fatigue and moderate lower extremity edema. He has a 15-year history of poorly controlled hypertension. Blood pressure is 195 over 110. BUN is 70. Creatinine is 7. 24-hour urine sample contains 300 milligrams of protein. Which of the following is the most likely pathologic finding in the kidneys? So this guy has hypertensive emergency, very evidently, right? He's got end organ damage to the kidney already, and they want to know what you would find in terms of pathology in the kidney. And as soon as you see fibromuscular hyperplasia of the arterioles, you can just log that in, right? Because you know fibromuscular dysplasia is a thing for hypertension. In fact, in the book, when they talk about hypertension the first time, they show you the beating, right? This is the beating that you're supposed to see. There's another image of the same thing. NBME 23 also has a question about fibromuscular dysplasia, as you can see right here. So this is a pretty high-yield topic for NBME, if anything. But yeah, when you have the characteristic string of beads appearance of the renal artery, that's something for fibromuscular dysplasia, and this is usually seen in females. I know this is a 56-year-old male, but the other thing is the other answer choices didn't really make sense. You're not going to have coagulation necrosis, right? That's not the kind of necrosis you get with arteries. Arteries and blood vessels do not get coagulation necrosis, right? Answer choice C, inflammatory cell infiltrate in the interstitium. Why would you have inflammatory cell infiltrate? This is just hypertension. Large electron-dense deposits in the glomeruli is actually related to a certain type of renal pathology, but not hypertension. Multiple renal artery aneurysms, that's not really significant either for hypertension. And wedge-shaped cortical infarcts, that would be from lack of blood supply. If you cut off the blood supply to the kidney, then you get that, right? That's a sign of hemorrhage right there. So those things all didn't really make sense. This patient is going to have hyperplastic arteriosclerosis involving the thickening of vessel walls by hyperplasia of smooth muscles, and that gives it the onion skin appearance. Consequence of malignant hypertension with acute end organ damage, hypertensive emergency. Results in reduced vessel caliber with end organ ischemia, may lead to fibrinoid necrosis, right? Blood vessels get fibrinoid necrosis. Classically causes acute renal failure with a characteristic flea-bitten appearance, which I've never really seen being described, but is something you can watch out for. And then Robbins talks about fibromuscular dysplasia in a pretty good way as well. But all in all, this was a pretty straightforward question. Just don't get too confused by the other answer choices. Alright, number 5. This is one of my favorite type of questions to get. I love this stuff. Every time a question on this pops up. An otherwise healthy 4-month-old girl is brought to the physician because of the lesion shown. The lesion has been present for 2 months but has grown rapidly over the past 3 weeks. Which of the following is expected to over the next 5 years? And the correct answer was H, spontaneous involution. UWorld asked about this thing too. This is the strawberry hemangioma. Remember that strawberry hemangioma should remind you of strawberry shortcake, which is a doll for little kids. So you know that strawberry hemangiomas occur on infants or little babies, and UWorld taught you that, and First Aid says it too, that the strawberry hemangioma will first grow, then involute, and they gave you that. It's been growing, right? It's been growing rapidly over the past 3 weeks, and then all of a sudden it starts to go away. And the reason it starts going away is because it gets so big, but the stem is so small that eventually it gets too big to supply itself, and it dies. So it's like if you're growing a tumor on your hand or something, and then the blood supply for that tumor gets cut off, that tumor will just have to fall off. Something like that. So that's generally all there is to strawberry hemangioma. It's really straightforward. It compares to a cherry hemangioma, which usually occurs in adults. Right, so you can look at it right here. This is strawberry shortcake. The doll on the left is strawberry shortcake from a cartoon. Let her remind you that strawberry hemangiomas occur on babies. Right, and you can see right here too. In addition, you pop your cherry as an adult. That sentence should remind you that cherry hemangiomas occur in adults. Furthermore, adults do not change. Should remind you that cherry hemangiomas will not self-resolve or regress. And this is a cherry hemangioma. In fact, instead of self-resolving or regressing, it actually starts multiplying. So as you keep getting older, if you got one, you're going to get many more. Right, this thing on the far left is Kaposi sarcoma. Right, Kaposi sarcoma, this one. Right, endothelial malignancy most commonly affecting the skin, mouth, GI tract, often related to AIDS. Right, so that's your comparison of all 3 of those skin lesions, which you could tell that the age is a major influence as well, and then a backline story of what they were doing, if they have AIDS or anything else about their history, is also really significant. Number 6, a 50-year-old woman comes to the physician because of a 3-month history of a discharge from both breasts. She has a history of hypertension and type 2 diabetes mellitus. She takes hydrochlorothiazide. Physical exam shows a thin, milky discharge from both breasts. Which of the following mechanisms is most likely responsible for this patient's condition? Now, people chose all kinds of answers for this question. Actually, I wrote it here. See, the internet does not know how this is the answer. Because I asked a lot of people, and I'm part of a lot of forums. Most people were not sure. Like, if you know, then definitely feel free to reach out to me, email me what you think might have caused this. But the internet didn't really know how this is the answer. But it's definitely not breast cancer, because the discharge is bilateral. Diabetes and hypertension do not fit this issue either. Never do we really think of diabetes or hypertension leading to breast discharge. Systemic mastocytosis is actually something that NBME likes talking about. They've had other questions where the question was actually about systemic mastocytosis. And I can't remember very accurately right now, but I'm pretty sure either AMBOSS or UWorld, one of them had a question about systemic mastocytosis, but it's not in First Aid. So systemic mastocytosis is related to mast cell proliferation and increased histamine secretion, leading to gastric hypersecretion with ulceration and some skin manifestations like flushing. So how you get this question, and I describe it here because I feel like it's becoming a new high-yo topic. So systemic mastocytosis is going to be a patient with histamine-related manifestations. Remember, H2 blockers are something you take to stop histamine-related gastric secretion. So people with excess histamine will have gastric hypersecretion as well as skin manifestations of flushing because of the same histamine. And this patient will have excessive amounts of both things, and then you're going to have answer choices that look like gastric adenocarcinoma, Zollinger-Ellison syndrome, blah, blah, blah. But it's really just going to be systemic mastocytosis. And somewhere along this question stem, they might even mention like taking skin biopsies or something like that. Right? So it's just excessive mast cell proliferation and mast cells releasing excess histamine. This patient, whatever's happening to her was related to a drug effect. Right? Maybe something related to prolactin, dopamine, etc. But they really didn't give you anything in this question. And it definitely had nothing to do with hydrochlorothiazide. Right? It definitely had nothing to do with hydrochlorothiazide. If you look at hydrochlorothiazide, and I haven't looked at it actually, so let me see. It could be. But as far as I remember, hydrochlorothiazide doesn't do anything like that. Yeah, see, hydrochlorothiazide doesn't have anything to do with causing any kind of breast discharge, nothing like that. So it really doesn't make sense. It has nothing to do with the hydrochlorothiazide. None of the diabetes medications do it either. No diabetes medication causes you to have breast discharge. So this was a really messed up question that wasn't very accurate, but you could still somehow pick drug effect just because you would know it had nothing to do with the others. Although a lot of people that I spoke to and a lot of people that did do this question picked breast cancer because it's hard to kind of figure out what drug would do this too. So it's definitely not mentioned what drug would do it either. So there's that. This one, okay, 38-year-old woman comes to the physician because of a 3-day history of sore throat. During the exam, the patient is asked to protrude the tongue and say, ah. This causes elevation of the area at the tip of the arrow in the photograph shown, which is basically your uvula. Deviation of the uvula. Function of which of the following nerves is most likely being tested by this maneuver? And you have to remember all the cranial nerve and how to test them. So this is just the vagus nerve. You know that the facial nerve is for muscles of smiling on your face. Glossopharyngeal is more so related to your tongue and pharynx. Hypoglossal is also just muscles of the tongue. And spinal accessory is for the muscles out here, right? Your trapezius and stuff. So cranial nerve 10 checks the uvula. The uvula deviates away from the side of the lesion because the weak side collapses, so the uvula points away. So in this patient, since the uvula is pointing away from the lesion and the uvula is pointing to the left, this means that the right cranial nerve 10 for this baby has a lesion. Or, wait, this looks like a baby, but it's a 38-year-old, right? Yeah, 38-year-old. So the right vagus nerve of this 38-year-old woman is injured. Cranial nerve 5 lesions cause the jaw to deviate toward the lesion, while cranial nerve 12 lesions cause the tongue to deviate toward the lesion, right? So lick your own wounds, clean your own wounds, that kind of stuff helps you remember both of them. Cranial nerve 11 leads to a weakened sternocleidomastoid muscle, making it hard to turn your head the opposite way. But the shoulder droops on the same side, right? Because the trapezius. So if we go back to page 576, you can see those things right here. Okay, so yeah, the trapezius and sternocleidomastoid. So everyone is basically toward, everything is ipsilateral, right? Because even with cranial nerve 11, like it's the same side sternocleidomastoid and the same side trapezius. It's just the function of the sternocleidomastoid is to help you turn your head the other way. So that's different. But everything is ipsilateral except cranial nerve 10. That makes your uvula deviate away from the lesion. Okay, so definitely make sure you memorize these because we're going to get to that. We haven't gotten to this part of the pathology yet. But these are usually easy giveaway questions. And then understanding upper and lower motor neuron lesions and all of that. Very significant things, especially here, motor neuron signs. When we get to these things, I'm going to make sure I make my best attempt of having everything really easy to memorize. Today we finished up to here. We finished multiple sclerosis. So this is where I'll be starting up tomorrow when I do it. Or maybe even tonight. Although it's Friday night, so I probably won't be able to do it tonight. But yeah, I'm going to be posting a schedule on my community page pretty soon so I can keep you guys updated on everything. But the tentative schedule, it seems right now, is that weekdays, especially Monday through Thursday, 12 to 3 p.m. is going to be for NBME revision. 10 a.m. might be one session of first aid, and then 6 p.m. would be more sessions of first aid. So that's my tentative schedule that I'll be posting on the community page of my YouTube as well as on my Facebook page. Number 8, a 34-year-old man who is HIV positive is brought to the emergency department because of severe abdominal pain for 12 hours. So HIV positive abdominal pain. He's been getting antiretroviral therapy for the past 2 weeks. Prior to starting the medication, his CD4 T lymphocyte count was 35, which is pretty much zero. In addition, he was diagnosed 14 days ago with disseminated Mycobacterium avium intracellulare infection by a positive blood culture and enlarged intra-abdominal lymph nodes on CT scan. His temperature is 102, pulse is 104, and blood pressure is 110, so he has a high fever. The lungs are cleared auscultation, abdominal exam shows tenderness, a CT scan of the abdomen shows further enlargement of the lymph nodes since the previous CT. Improved function of which of the following cells is required for the development of these findings? So basically what they're asking you is what started working that caused him to have bigger lymph nodes now. The community page, when you go to the YouTube channel itself, you can see there's a couple tabs there. So some of the tabs are like home, videos, playlists, and then there's a tab that says community. That's the community page. So that's usually where I keep everyone updated on YouTube. So sometimes if you sign on to YouTube, you might on your homepage at youtube.com, you might see a post from me or anyone else who you're following if they post on the community page. And then I also have my Facebook page where I do post if anything significant needs to be said. So that's that. So in this patient has a bacterial infection. So it was already a giveaway that for bacterial infections, it must be CD4 lymphocytes. CD8 lymphocytes are usually more so for T cells. For viral infections. On top of that, they're saying the lymph node got enlarged, right? So if the lymph node got enlarged, that means that you have more lymphocytes. And more lymphocytes, you could pick between B, CD4, or CD8. You can already cancel out answer choice D and E. Natural killer cells and monocytes do not really have anything to do with making lymph node bigger. Okay, so if your lymph node got bigger and you have a bacterial infection, it must be because you have more CD4 T cells. That's it. Therefore, in an AIDS patient, to enlarge the lymph nodes, the CD4 dysfunction must be resolved. Right? And you know that you start losing function of CDs anyway because of AIDS. If we go back to, let me see, where they mentioned this stuff. Yeah. So you know that AIDS, virus binds to CD4, right? You lose HIV. HIV makes you lose CD4 activity because of the receptor. Which one is this? These guys, the CCR5 and the CXCR4. And you know that people who have mutations in their CCR5 are pretty much ending up being more immune, right? And I've always wondered, like, if someone's trying to figure out a way to make this happen by forcing people so that everyone can be immune to HIV. But it's hard to induce mutations in specific areas. Either way, for this question, they're talking about CD4, they're talking about HIV, and they're talking about a bacterial infection. Had this same question presented in a different manner, and the patient had a viral infection and their lymphocytes got bigger, then this question would not really be the same anymore, but you wouldn't be able to pick between answer choices here. Because if he had a viral infection, then he would be increasing CD8 lymphocytes. But if you're helping him with antiretroviral therapy, he's also going to be increasing CD4 lymphocytes. So that's why they didn't give the patient a viral infection. The patient had to have a bacterial infection, so it would make sense for you to pick CD4, and because it's HIV, which normally lowers the amount of CD4 you have. Alright, so CD8 was not relevant here. B lymphocytes was not relevant here either. Okay, so the most relevant thing for improved function was for CD4, because his B lymphocytes should be functioning fine to begin with. HIV doesn't necessarily do much to B lymphocytes. It's improved function of CD4 lymphocytes that is now causing him to have enlarged lymph nodes, and the lymph nodes are enlarging because he's fighting the bacterial infection. Number 9, a 6-week-old girl is brought to the physician by her mother because of a 6-day history of vomiting a small amount of milk 2 to 3 times daily. She appears well. She's at the 50th percentile for length and weight. Physical exam shows no abnormalities. What is the most likely cause of this patient's findings. And then this is the third question with these answer choices and the same NBME. We've already seen two questions, one where the answer was pyloric stenosis and another where the answer was Meckel diverticulum, I believe. Now we're looking at this one. So you need to be able to cancel out answer choices based off of the information provided, right? First thing you look at is age. So it's still a really, really young infant, 6 weeks old, so a month and a half, right? So it's pretty much possible for it to be almost any of these. But then one really important sentence here was that the fact that she appears well. She appears well. If you have a tracheoesophageal fistula, you're going to be not appearing well because you're kind of choking, right? Because esophagus is sending food into the trachea, so you're going to be choking, and you're going to have some hypoxia, some cyanosis, stuff like that. So you can cancel out F. A pyloric stenosis is a very easy question because, mainly this is going to be something related to food, and the vomit is not going to be bilious because it didn't even go past the stomach. And remember, bile is added at the second part of the duodenum. So if the food isn't even going past the stomach, you're usually going to have an add up of food that comes back with a lot of force, right? Vomiting with a lot of force. But this patient is vomiting liquid stuff, which should be able to go through the pyloric stenosis pretty well. Vomiting small amounts of milk. So then you start looking at other answer choices. An esophageal spasm. First of all, although possible, esophageal spasms are really rare in this age. On top of that, they didn't give you anything for you to really pick a spasm in the esophagus. Right? They didn't give you any kind of test they did of the esophagus. They didn't give you a manometry exam thing. Let me show you what I'm talking about. So right here, when you talk about achalasia and everything, right, this thing, they didn't give you one of these. You have to do a manometry finding. You have to do a manometry finding to really be able to diagnose how the peristaltic waves in your esophagus are working, right? And the diffuse esophageal spasm would look like this, but they didn't give you that, so you can't really pick that. Immature lower esophageal sphincter is something plausible, especially because of the word immature. She's 6 weeks old, so it's making some sense. Neuromuscular abnormality of the esophagus is also plausible, and that's it. So you're really just down between C and D. Now if you look at this video I found, let me show it to you guys. I'll put it here too. So this video is with this Dr. Viren Virasuria, some Indian doctor, pediatric gastroenterologist, where they really talk about diagnosing GERD in children, right? You rarely ever really think about diagnosing GERD in a child, but it is a thing. It's definitely a thing. It can happen, often gets overlooked, and you obviously want to make sure you understand how to work with that, because GERD, as bad as it is for adults, it's really bad for kids too. So the baby is actually fine with no major failure to thrive, right? That's the first thing you should realize. The baby is doing okay. Being at the 50th percentile for length and weight is not really that bad. I know that because they put that sentence there, it can make you think that the baby's not thriving, but it's just a measurement. It's a measurement of length and weight, and maybe the baby is not going to be that heavy, maybe the baby's not going to be that big yet, but growth occurs in weird ways, and the baby might suddenly, in like another month, be at the correct percentile. Spasm would have dysphagia and angina-like chest pain with corkscrew barium of the esophagus. None of that was given. They didn't give you the manometry either. Pyloric stenosis would have non-bilious projectile vomiting with a lot of force. Tracheoesophageal fistula would have to have cyanosis due to the laryngospasm or choking spells. Malrotation of volvulus would be painful. Both of those things tend to be painful. Volvulus in an infant is midgut, whereas in an elderly patient is more towards the end. But none of that is given. So you can cancel out all the answer choices. D, the neuromuscular abnormality of the esophagus, is very similar to saying the esophageal spasm, because an esophageal spasm is a neuromuscular abnormality of the esophagus. So those are the same answer choices. All right. Number 10, a 66-year-old man has had fatigue, shortness of breath, and temperature to 40 degrees Celsius for a week, which is really high. An X-ray of the chest shows cavitary lesion with a fluid level in the right lower lobe of the lung. And he's really old too. Culture of the sputum grows Klebsiella pneumoniae. Symptoms resolve with antibiotic treatment. Which of the following is most likely to be found in the right lower lobe 6 months later? So basically, this guy had a cavitary lesion in the lower lobe. It was full of Klebsiella, and then they resolved it. They fixed him. So he's okay now. But what are you going to see 6 months later? And then you get all these answer choices, only one of which is a sign of recovery. Okay? Focal pulmonary fibrosis is a sign of recovery. Focal means in one area. Pulmonary fibrosis usually occurs anywhere you had injury. Granulomatous inflammation would be a sign of infection. Liquefactive necrosis would also be a sign of infection or some kind of damage that's still going on. Metaplastic pulmonary epithelium doesn't really make sense. Why would you have metaplasia of pulmonary epithelium after the thing has been resolved? There's nothing like that. And normal pulmonary parenchyma really doesn't make sense. Why would you see normal parenchyma when this guy actually had a cavitary lesion? That lesion has to be healed. So a radiographically visible air fluid level suggests a pretty large lesion, hence the word cavitary. That's not going to become normal tissue again. 6 months following resolution of symptoms, you can expect healing in the form of a scar. That is fibrosis, but only in a single spot. Focal pulmonary fibrosis. All right. Number 11, a 75-year-old woman goes to the physician because of a burning, itching sensation on the right side of her chest for 7 days, and a rash in this same area for the past 3 days. Her temperature is 99.1. Examination shows clustered skin lesions overlying 2 ribs near the right axillary line in the mid-thorax and on the back near the right scapula. So some weird stuff's happening, but notice how everything's on the right side. And she's 75, right? Really, really old. So already you can kind of start figuring out this looks like shingles. Some of the lesions are fluid-filled blisters and others have crusty scabs. Light microscopy is most likely to show which of the following. Now, once you figure out a shingles, you need to remember what shingles is and what it looks like. If you look at all the answer choices, branching fungal hyphae you can cancel out. This is not fungal. Diffuse separation of dermis and epidermis is actually, you should know what that is. If you have separation of dermis and epidermis, that falls under the category of bullous pemphigoid versus pemphigus vulgaris. Here, that would be bullous pemphigoid, separation of dermis and epidermis. Granular deposits of IgA at the tips of dermal papillae completely doesn't make sense. That, whatever that's related to, would be on both sides, not just on one side, right? It wouldn't be unilateral, everything on the right side for this patient. Immunofluorescent staining for C3 along the epidermal basement membrane. That is, once again, along the same line of bullous pemphigoid versus pemphigus vulgaris. And I believe if it's on the epidermal basement membrane, that's again bullous pemphigoid. So that can't be it either. Multinucleated giant cells and neutrophil infiltrates seems the most plausible because that's what you get with viral infections. Non-branching fungal hyphae, again, it's not fungal, so you pick E. Right? This is an example of shingles. Herpes simplex and herpes zoster cause abnormal cell division in epidermal cells, creating multinucleated giant cells. A Zank smear showing multinucleated giant cells is characteristic of varicella zoster virus. HSV would also have a Zank smear with multinucleated giant cells. Other identifying terms for herpes are the fact that it's a single dermatome, which does not cross the midline, painful because it's got the burning and itching sensations, and lesions in multiple stages. Right? Some of them were crusty, whereas others were fluid-filled. Right? So this is herpes zoster virus. Okay, so that's that. Number 12. 60-year-old woman with type 2 diabetes is brought to the emergency department because of a 16-hour history of substernal chest pain that radiates to the left arm. Her pulse is 110, respirations are 18, blood pressure is 96/60. Cardiac exam shows no murmurs. Diagnosis of an acute MI is made. 2 days later, the patient develops acute respiratory distress. Physical exam shows JVD to the angle of the jaw. Crackles are heard over the lower half of the lung fields. A grade 4 out of 6 apical systolic murmur is now heard. Which of the following is the most likely mechanism of this patient's worsening condition? So this is clearly the progression of an MI. That's kind of what the question is about, right? She had a diagnosis of MI and something happened 2 days later. So now you have to remember the progression of an MI and what are all the things that can occur very, very soon after an MI. You start looking at all your answer choices: cardiac tamponade, necrosis of membranous interventricular septum, pericarditis, right ventricular aneurysm, or a rupture of the papillary muscle. Where an MI is a myocardial infarction. And following an infarction, you get rupture of muscle because it's not getting the right blood supply. Later on, you can get these other things too. These are all actual viable progressions of an MI, but within the 2 to 5 day region, right, the two most important MI complications that occur early after an MI are papillary muscle rupture and interventricular septum rupture. Right? They gave you something for interventricular, but this is necrosis. Necrosis is death. That's not what happens. It's just breaking down. Rupture is what occurs. Papillary muscle rupture leads to severe mitral regurgitation, which is heard as a systolic murmur at the apex. And that was also a giveaway of the papillary muscle stuff. They gave you the systolic murmur that she has now is because she lost her papillary muscle there. So if you go to page that discusses all of that, progression of an MI, you can see it here, right? So it's got a breakdown within days. UWorld also has a table like this one. Right, so 0 to 4 hours minimal change, 4 to 12 hours coagulation necrosis occurs, and you start seeing wavy fibers. In 12 to 24 hours, you're going to start having the coagulation necrosis even more with marginal contraction band. And this table is really just talking about all the light microscopy findings. Complications are discussed by first aid, whereas right after the first day, on the same day, you can have a ventricular arrhythmia, heart failure, or cardiogenic shock because fluid is backing up into the lungs, all of which makes sense. Within the first 3 days, you can have post-infarction fibrinous pericarditis or free wall rupture, right? This is also within 3 days, free wall rupture. Later on, within the first 2 weeks, you can get the mitral regurgitation from other stuff rupture as well, right? Papillary muscle rupture, free wall rupture, interventricular septal rupture, everything starts rupturing because the blood supply is not that good anymore. And then later on, you can get autoimmune stuff and true ventricular aneurysms. So for this question, none of these other things really fit the the scenario that the patient is presenting with, except E, right? Because they gave you the systolic murmur. 13, 28-year-old man who is a migrant worker comes to the clinic because of fatigue and back pain for 6 weeks. So he's really young though. He has had a 13-pound weight loss during this period. His temperature is 100.9 F. When placed in the supine position, the patient holds his right lower extremity in rigid extension. A PPD shows 16 millimeters of induration. X-rays of the chest and spine confirm tuberculosis of the lumbar vertebra. Spread of this infection from the lumbar vertebra is most likely causing this patient to guard which of the following muscles while he is in the supine position. So anytime you get a question like this, 28-year-old, a young person with some kind of infection, usually tuberculosis, and they're doing this weird guarding behavior with lower back pain, it's always psoas major. Right? UWorld also has a question where they discuss this. This is called a psoas major abscess. And let me show you what they're actually talking about. So if you come here, this is the UWorld question. Right? So 26-year-old man comes to the emergency department with fever, right flank pain, difficulty walking for the past 3 days. 1 week ago, he was treated with cephalexin for furunculosis. He was diagnosed with type 1 diabetes 10 years ago and takes insulin. So that's not even relevant. You can cancel that out because he's diagnosed with something, but he's treating it. He resists simultaneous extension of the leg and thigh, particularly at the hip. The pathological process occurring in him most likely involves which muscle? Psoas major. Alright? He most likely has a psoas abscess. The psoas muscle arises from the transverse processes of the 12th thoracic through 5th lumbar vertebrae. It then courses downward across the pelvic brim, anterior to the hip joint capsule, and deep to the inguinal ligament to insert into the lesser trochanter of the femur via a tendon shared with the iliacus. So you need to know that anatomy, but not so much. You don't need to know it that well. The iliacus and the psoas muscles are the major flexors of the hip. Psoas abscess can occur due to direct spread of infection from an adjacent structure or from hematogenous or lymphatic seeding from a distant or possibly unknown site. Risk factors include diabetes, IV drug use, HIV, and other forms of immunosuppression. And here, this is your erector spinae muscle, this is your psoas major, This is the quadratus. All the muscles are kind of nicely labeled here. And the psoas major is on both sides, so that's why they end up presenting with lower back pain, right? Because the muscle is kind of pulling at it. And that's a pretty significant topic. UWorld asked about it. NBME is even asking about it. So make sure you know. If you have this presentation, you pick psoas major. The other muscles, erector spinae, we just saw in that image too. Right, so it's relevant, but not exactly something that was causing this patient's presentation, because the erector spinae keeps you erect. It's really just there to keep you standing tall, but it wouldn't make you do what this patient is doing, where he's like pulling his legs in. Holds his right lower extremity in rigid extension, which was a weird description. A lot of people online complained about that, because holding it in rigid extension doesn't match what happens here in UWorld, where he keeps it flexed, right knee is flexed and externally rotated. So there's some difference there, but either way, this weird stuff that this guy is doing would not be related to the erector spinae. Right, the iliacus and psoas major are in the same area, so they put everything there. But you always have to remember psoas major abscess is what's happening when you get a question like this. Okay, number 14. So, 60-year-old man comes to the physician because of a 6-week history of cough productive of blood to his sputum. He also has had a 3-kilogram weight gain during the past 8 weeks. He has smoked 1 pack of cigarettes daily for 30 years. Blood pressure is 165 over 101. Lungs are clear to auscultation. CT scan of the chest shows a pulmonary lesion. Lab studies show a serum sodium concentration of 122. Physician suspects that this lab abnormality is related to pulmonary lesion. Which of the following additional sets of lab findings is most likely in this patient? So they gave away what's happening to this patient by mentioning the pulmonary lesion part, and the fact that you're talking about serum osmolality here. So this patient has small cell carcinoma. This type of cancer is associated with paraneoplastic syndrome such as Cushing syndrome, SIADH, or Lambert-Eaton. Amplification of the MYC oncogene is also common. And how do you talk about SIADH? Well, ADH is antidiuretic hormone. You stop peeing. So if you stop peeing, you retain a lot of water. And SIADH is antidiuretic hormone. It's supposed to help you stop peeing. And in this disease you have too much ADH. You have too much ADH, so you stop peeing water. That's the main thing here, right? So you end up having excessive free water retention. You're going to have something they call euvolemic hyponatremia with continued urinary sodium excretion, because aldosterone starts doing its thing too. The body responds to water retention with aldosterone and ANP and BNP. That is what causes the increased urinary sodium secretion, which leads to normalization of the extracellular fluid volume and the euvolemic hyponatremia. You want to make sure you understand that, especially because UWorld also talks to you about the euvolemic hyponatremia aspect. So now if you look at all the things here, only one answer choice obviously fits what's happening, and it's going to be B. The urine sodium is going to be increased, right? That's why his serum sodium is low. He's going to be peeing out a lot of salt, and the serum osmolality is going to be decreased. Right? Serum osmolality, the serum sodium concentration, right? Remember, osmolality is pretty much synonymous to sodium concentration, and his serum sodium concentration is going to be low because he has a lot of fluid in his body, and because he lost his sodium. So 2 reasons, right? And because of 2 different reasons for his serum osmolality to be low, the serum osmolality is usually very, very low in SIADH. So this was a really easy question. You just have to make sure you understood what SIADH is. And if you don't remember how ADH works or what SIADH does, and the fact that aldosterone and ANP and BNP would also play a role, then you get a little confused. Keep in mind also that these patients will not necessarily have edema, because the aldosterone escape mechanism kind of works here too, thanks to ANP and BNP. So that's another thing that you want to keep in mind. Number 15, a 9-year-old girl is brought to the physician because of poor growth during the past year. She is below the 3rd percentile for height and at the 10th percentile for weight. Physical exam shows no other abnormalities. Visual field testing shows bitemporal hemianopia. Lab studies show growth hormone deficiency. An MRI of the brain shows a calcified cystic mass in the suprasellar region. So you have to remember what's there, right? We did neuroanatomy very recently, You need to remember what's in the supracellular region. This tumor is most likely derived from which of the following? And then you look at all your answer choices, and you remember the sella turcica is kind of where your pituitary is sort of sitting there. So it must be something related to the pituitary. And you look at all the answer choices, and A is really the only one. Diverticulum, the root of the embryonic oral cavity. What a weird way to talk about oral ectoderm, right? They're talking about the Rathke pouch. So this patient has a craniopharyngioma, most common childhood supratentorial tumor, derived from remnants of the Rathke pouch. Calcification is very common, and you often see cholesterol crystals found in motor oil-like fluid within the tumor. A cystic supracellular mass with calcifications and enhancement of the wall or solid portions in a child is almost always a craniopharyngioma. You could confuse this with the pituitary adenoma, but you have to really see what the question is giving you, one or the other. They're usually in the same area and often have a very similar presentation. So this thing, craniopharyngioma, right? Images G and H, right there. The H being the most specific thing. Make sure you really pay attention to the histological things when we get there, because especially here you could tell this one has the most unique histology, but they're all different from each other, so don't just look over any of it. Make sure you grab it very well. Okay, so that was it for that. Alright, this one was pretty cool. So this one, they give you this entire big ass sequence. They've labeled it so you can find out where in the sequence they're trying to get you to point at. The sequence surrounding the first 2 exons of the human beta globin gene is shown with the exons given in bold capital letters. The translation start codon is underlined, and that's right there. Okay, ATG. A mutation from G to A at position 355 is most likely to lead to beta thalassemia by which of the following mechanisms? So if you already remember the few things that can cause beta thalassemia, you would know what the answer is. And splicing errors can cause beta thalassemia. So that's one thing. But let's say you forgot that if you look at what they're talking about, so they say position 355, right? So that's right here, right? They're saying that the G, right, a mutation from G to A at that position. So that G is going to become an A. What would that do? So now you can see that that is an error occurring in an intron, right? Introns are intervening. Introns are mostly just things that need to be spliced out. If you have an error in an intron and this G becomes an A, then you would have AGT, right, or TAG. Either way, you would get that kind of thing happening. And if you look at right here, right, you see how you have AG, right? AG. AG is actually really, really significant when it comes to splicing. And it's something that many people look over when they study the splicing stuff. So splicing is on page 42. And they do show it to you, but obviously first they don't really talk about it per se, but it's shown to you. You can see the AG right there. Right? In fact, splicing keeps occurring at places that end in GU and AG, just like that. Right? There's a branching point. The branching point is also usually an A. Right? So if you're changing an A, or if you're making something into a brand new AG, then the AG is now going to be a new place for you to cut things. Right? So any of these changes, so you turn this G into an A, now you have a brand new AG, so you're going to splice right here, and the new protein is going to have all of that in it. Everything from there to there is going to be part of that exon. So you mess up splicing. So now if you look at the answer choices, creation of a missense mutation that leads to synthesis of a defective beta globin, that's not what a splicing error looks like. Disruption of normal splicing is obviously what we're talking about. Disruption of the polyadenylation of the mRNA is not relevant at all. inhibition of the replication of this gene is actually not done like this either. None of those C and D don't make sense at all. The splicing usually happens at GT or AG areas for both of the two different ends, and you can see that the current splicing and end areas are from 241 to 361. That's where it happens, right? From here all the way to here, right? Those are your two current splicing areas, and you can see that. You see the AG and you see the GC, right? So, or actually more so, look at the lower letter stuff. The GT is the lower letter stuff, and the AG, right? So GT, AG. Always think of G tags, like gangster tags, right? You always want to think of G tag. So G tag is the splicing stuff, and you can see your GT right there and the AG right there. That's your normal splicing. So those are the two areas you're going to splice at, and some A in the middle will be the central thing that you'll curve it all into, right? The branching point. It'll be some kind of A. Any one of these A's in the middle can be your branching point. So if you mess that up and you make a new AG over here, you moved your G tag up a little and your splices are going to look different, and that's it. Okay, so always remember the G tag for splicing. Gangsters will cut you, something like that. So splicing is cutting. Gangster tag. Number 17. Alright, this one was a nice question too, really related to neurology again. A 70-year-old man dies of coronary artery disease, so he's really old. He had a cerebral infarction 8 years ago. A photograph of a specimen of the brain stem is shown, and that's what they gave you. And they labeled left and right on it. Remember that usually this kind of image is given to you the other way, whereas these things are at the bottom. Which of the following neurologic deficits was most likely present in this patient after his cerebral infarction? Okay, so when you look at it, remember that symmetry is a really big deal, right? And everything up here looks okay. The most notable thing is that this is dark and this is not. So something went away from here, right? He lost it. So if you look at all the different answer choices, dysmetria, loss of joint position sense, and spastic hemiparesis. Each one of those three things is related to a completely different tract. Dysmetria is one thing, loss of position and sense, right? That's another tract. And then spastic hemiparesis, that's your corticospinal tract. When you look at the image, then I put this normal image here. This one is the one with everything correct and it's labeled. So you can see what they're talking about. You lost this stuff, right, in this patient. You lost this stuff right here. And when you get that kind of infarct, you want to make sure, when I talked about the tracks in my neurology videos, it's really, really on point. I actually had to record it 3 times to get the tracks correct. Your dorsal column is the one for vibration and proprioception. And loss of joint position sense, right, answer choices C and D are related to your dorsal column. This is not about the dorsal column at all. This is not your dorsal column, so you cancel those answer choices out. Spinal thalamic tract is for pain and temperature, and your corticospinal tract is the only descending one you really need to know about, which is for actual voluntary motion. And this guy, they tell you that this infarct, well, they don't tell you, but they show you, this infarct is kind of in the same area of where you would have your crus cerebri, right? You can see your substantia nigra is being pointed out. And if you look at the tracks here, right, let's look at which one is, this is ventral spinal thalamic, yeah, corticospinal tract. So you can see this is the brain level stuff we're looking at, right? This is the brain stem level that we're looking at. What is this? This is your dorsal column, corticospinal tract. Here we go. So this stuff, let me show you on the same page so we can really kind of compare what we're talking about. So if we look at our corticospinal tract and the stuff they gave you in this question, this layer that they gave you is this one here. Okay, you see your the pyramidal stuff, right? Those are your pyramids back there. All right, so if you lose this area in the front, right, that's gonna mess up this entire area that we need. We need this entire area for your corticospinal tract to work correctly. You have your pyramidal decussation, then it goes to your arm and goes to your leg, and that's it. And that's all different stuff. We're using different nuclei that you need to look up. If you haven't watched the neurology video for this, you really need to spend some good time with it. It was perfect the way I described everything. So here, if any of that is messed up, that's all a sign of injury to motion, right? So this patient is going to have spastic paresis, And then they ask you on what side. Well, that's just a trick question. If the injury is in the brain and things are decussate, then obviously it's going to be on the other side. So F, spastic hemiparesis on the right. Okay. 18, a 33-year-old woman comes to the emergency department 1 hour after she slipped on an icy sidewalk and fell onto her outstretched right hand. Physical exam shows swelling and tenderness to palpation centrally. One second, I'm getting a phone call from my mom. Okay. Always gotta take those phone calls from mom. Can't ignore that. Where was I? Okay. Physical exam shows swelling and tenderness to palpation centrally of the palmar side of the right wrist. Palpation of the right anatomical snuff box and the remaining portion of the wrist elicits no pain. The most likely cause of the findings in this patient is a dislocation of which of the following bones. So you really only need to know a couple of these bones, and you should be able to identify them on an x-ray very well, because the capitate is a really big guy. So let's actually go take a look at that. So if we go to page 481. So when you look at this, right, the capitate is the big guy in the middle, and he's sitting on top of the lunate, right? So cap on top of luna. And then from there, the rest of them you should kind of be able to play out. You know your scaphoid, you know the T and the P right there. The sentence so long to pinky, here comes the thumb is also a great way to work with it. Your capitate is just a really good landmark for you to start actually working with, right? Now, they described a couple things for this patient. They tell you that slipping and falling on the outstretched right hand isn't exactly pathognomonic for one thing. We wish it was, but it's really not. It could be either one or two different bones. But the rest of the stuff, physical exam, that's what really helps. They tell you that the palmar side, right, physical exam shows swelling and tenderness to the palmar side of the right wrist. Palpation of the right anatomical snuff box does not elicit pain. So it's not the snuff box stuff, it's the other guy. And when you come here, you know, there's only so many bones that you have to worry about. Scaphoid and lunate are discussed right here. They tell you that the scaphoid is palpable in the anatomical snuff box, and you would have pain because scaphoid is the most commonly fractured carpal bone, typically falling onto an outstretched hand, like our patient did. And then dislocation of the lunate can cause acute carpal tunnel syndrome, right? And neither of those were the actual issue for this patient. Right, this patient, well, not the scaphoid one, but the B, lunate, right? B was the one for this patient, lunate. Because if you look at anything else, she doesn't have the biking injury, right? The other one is the biking injury. So let's take a look. Capitate and lunate are in the center of the palm. Capitate is not an option, so lunate has to be the answer. Because they tell you another thing, right? They tell you something about, centrally located, right? Tenderness to palpation centrally. That was the major giveaway in this question, which was really weird and awkward. Wouldn't really ask you a question in this manner, but they were pointing at a bone that's centrally located, and capitate and lunate are the only ones, so you go with it. But even without that information, you can still do it. Since the snuff box is not causing any pain, you know it's not scaphoid, so you could lock that out. Trapezium and triquetrium are usually never really answer choices. The only other thing that is scaphoid and lunate, and then the hook of hamate. The hook of hamate can cause Guillain Canal syndrome in bikers due to ulnar trapping, and that's not something this patient had either. Right? So this patient only has pain. There's no denervation. There's no denervation, because if there's denervation, the muscle will atrophy, and based off of which side you're either thinner will be under the thumb, and hypothenor, any one of those things, if they disappear, that's a sign of denervation, at which point you pick, you know, either lunate or scaphoid, or the snuff box is mentioned, or your hook of hamate for the ulnar nerve stuff. None of that happened, so you could safely pick lunate. It is in the middle. Capitate sits on top of lunate, and you're done. You know, so it's a slightly difficult question for those who forgot this anatomy, but you definitely want to make sure you keep revisiting it, because it's really not something you want to forget. It's usually a pretty easy question, as long as you have good memory of what's actually happening in that question. Number 19, a 36-year-old man comes to the physician because he has not urinated for the past 24 hours. He has a 3-day history of decreased urine output. He has had intermittent renal calculi during the past 5 years. His temperature is 98.4 F, pulse is 112, blood pressure is 150/96, physical exam shows no other abnormalities, and serum studies are given. So in the serum studies, most notably, you're kind of seeing the potassium 5.9, and then the creatinine being 5. So those two things are really significant. Ultrasonography of the abdomen shows bilateral hydronephrosis. Bilateral nephrostomy tubes are placed. Which of the following best predicts the most likely changes in urine output and urine potassium excretion that will occur during the next 24 hours? Well, if you're putting nephrostomy tubes, right? If you're putting nephrostomy tubes, you're obviously going to increase urine output. So automatically we're down to D, E, and F. You're going to increase urine output. That's the reason you're putting nephrostomy tubes in there. And if you're going to increase urine output, now the question is, what's going to happen to urine potassium? The tubes are catheters put in for urine to flow into a bag. So urine output is going to increase. The patient is also hyperkalemic. Aldosterone responds to hyperkalemia by increasing potassium excretion. Hyperkalemia will stimulate aldosterone secretion even if renin is suppressed due to his hypertension. Although sodium will be reabsorbed, this will be transient, should resolve once the potassium level is normalized. And since his urine output will likely return to normal, since his urine output will most likely return to normal, his blood pressure should also normalize. Post-obstructive diuresis is a polyuric state in which copious amounts of salt and water are eliminated after the relief of the urinary tract obstruction. Right, so it was a pretty easy question in the sense that you didn't really need to think too much about any of it. Patient has excess potassium and urine is all stuck, hydronephrosis. Once you get him peeing, he's going to pee out the excess potassium. That's kind of what our kidney does, pee out excess stuff. Right, so it's just E, increased, and that's it. 20, a 56-year-old man is admitted to the hospital after an automobile collision that resulted in crush injuries to both legs. 36 hours later, he develops oliguria, hyperkalemia, and an increased serum urea nitrogen. Which of the following is the most likely cause of these findings? Okay, so this again was like a very obvious answer choice, but if you look at everything anyway, contussion of the kidney doesn't really make sense. Contussion of the kidney would not really be something that presents 36 hours later. A fat embolus would probably be something that would go to your lungs. Remember, things from your legs go to your lungs, like a DVT embolus. Also remember that primary bone tumors of your legs also metastasize to the lungs. That's also something Pathoma talks about. So remember that everything from the legs goes to the lungs. So this is not something that happens to his lungs. His kidney is just not seeming to work correctly. Renal vein thrombosis, maybe, but again, kind of unlikely for 36 hours later. So you see rhabdomyolysis, and he had crush injuries to both legs, so you could pick that. Muscle breakdown releases a lot of things, and a lot of things can just go to the kidney and mess up your kidney too. So rhabdomyolysis can present looking like a kidney injury. It can lead to acute tubular necrosis as well. The electrolyte findings are just like renal failure. To differentiate between rhabdomyolysis and kidney injury, you check the urine to see if there are any red blood cells. In rhabdomyolysis, there are no free red blood cells in the urine. Crush injury is practically a buzzword for rhabdomyolysis. Right, so that's all that happened here. And they tell you that the patient just had oliguria, hyperkalemia, and increased serum BUN, but they didn't mention any red blood cells. So that's something you can keep in mind. Other than that, the other thing you can think of, remember from your multiple things in renal pathology, this one page that talks about all the AIN, ATN stuff. ATN was related to hospitalized patients, right? And this was a scenario where you have an oliguric phase. And our patient is having oliguria. So this patient's presentation looks just like acute tubular necrosis. Right? Everything is fitting the scenario of acute tubular necrosis. If they put that as an answer choice here, you would be very much inclined to pick acute tubular necrosis. But you wouldn't, because acute tubular necrosis is not going to be as a result of, per se, the rhabdomyolysis. Acute tubular necrosis is resulting from one of these two things: injury resulting from toxic substances, crush injury. This is actually the one we have for our question. But they wouldn't put both things as answer choices. But this is what we have right now: myoglobinuria. And any of these nephrotoxic and ischemic things can lead to acute tubular necrosis. So I guess in a sense you could say that our question is about acute tubular necrosis. They just didn't put that as an answer choice, right? So this answer choice could have also just been acute tubular necrosis, because that is what this presentation is. You have a hospitalized patient who is oliguric. Anytime you see that, you think of ATN, acute tubular necrosis. Right? And his one is this specific scenario, the crush injury. Right? I didn't even think of that when I was explaining this. So now that becomes even more clear. Okay, so that's a pretty nice question. A lot of people got it wrong. Many people wanted to pick fat emboli. A couple of people picked renal vein thrombosis because of all the renal difficulties this patient is having. But renal vein thrombosis does not make you oliguric. So that's one thing. Contusion of the kidney is also a thing that a lot of people wanted to pick. They thought that maybe because of the accident the kidney got injured. But if it did get injured, a lot of things, renal vein thrombosis, contusion of the kidney, stuff like this, would cause you to sort of have blood in the urine. And they don't give you any of that. Alright, so that's generally it there. 21. A 37-year-old nurse is accidentally stuck with a needle used to obtain blood from a patient who is HIV positive. Because of the severity of the exposure, she receives 3 antiretroviral agents. 4 weeks later, she develops anemia and neutropenia. Which of the following best describes the mechanism of action of these antiretroviral agents that is most likely responsible for the anemia and neutropenia? So you look at your answer choices: inhibits reverse transcriptase, inhibits viral integrase, inhibits viral protease, prevents binding to CD4, and prevents release of virus from infected cell. You can cancel out E immediately, actually, right? Because preventing release of virus from infected cells is actually a medication you use for the flu. Right? So influenza stuff, actually, not the flu. You use it for influenza, and it's not really, that's not what our case scenario is here. Now, majority of the medications are actually ones that stop reverse transcriptase. Integrase and protease inhibitors are different medications that have their own set of side effects that you really need to make sure you spend some time and memorize and think about it all the time. NRTIs are actually guys that stop reverse transcriptase. So in a sense, they stop transcription, and when you stop transcription, it's kind of like taking a medication for cancer. You end up having bone marrow suppression, right? This can be reversed with GCSF and erythropoietin and stuff like that, but they haven't gotten to that point with that patient. Specific side effects you want to remember is zidovudine causes anemia, and didanosine causes pancreatitis. Those two are very specific. And abacavir is one that you can't give to HLA-B 5701 patients because they would have hypersensitivity. Silly questions you can get on those things are very possible. And NRTIs, there's only 3 of them, and these guys cause rash and hepatotoxicity. So that didn't happen to our patient. Protease inhibitors also have issues, but these guys are more systemic issues because it's a protease. Remember that a protease's job is to break down proteins you don't need anymore. It's not going to inhibit transcription or translation. So if you break down proteins you don't need anymore, or you break down the wrong proteins, or you don't break down proteins even though you should have, those things usually cause metabolic side effects, right? So you see the hyperglycemia, nausea, diarrhea, Cushing, stuff like that. Integrase inhibitors, they don't really do anything. No major side effect. An elevation in CK, that's not that big of a deal. Infibutide and Mevaroc, again, not much to talk about in terms of side effects. So just based off of knowing the fact that NRTIs usually cause the most side effects, you could have just picked A, right? Because B and C don't really cause major side effects, and neither does D. None of these guys usually cause major side effects. The protease we just talked about, those guys cause metabolic side effects. This patient doesn't have a metabolic side effect, she has a hematologic side effect. And anemia and neutropenia are signs of not being able to do cell division. So you must be inhibiting transcriptase. And that's generally how you want to work with these kinds of questions, especially if the question isn't asking you about a very specific medication, but just the general class of medications. Number 22, a 1-month-old male newborn is brought to the emergency department by his mother because of a 5-day history of vomiting after feedings. This is the fourth question about something like this: infantile GIT embryology. His mother says the vomiting is forceful and appears to contain only formula. So that looks like the hypertrophic pyloric stenosis stuff right there. She says he seems eager to feed after each episode. He appears irritable. He's tiny. His temperature is 99.7. Pulse is 140, but that's pretty normal for newborns. Infants and newborns tend to have very high pulse. Respiration is 24. Blood pressure is 80/40 because of the vomiting. Physical exam shows decreased skin turgor. Which of the following sets of serum is most likely? So you just want to remember this from vomiting stuff. The book does talk about it too. So 383, which is 353 for actual FA 2019. Hypertrophic pyloric stenosis, they tell you that it results in hypokalemic, hypochloremic, metabolic alkalosis. All right. So the vomiting causes loss of HCl. You lose H and you lose chloride. Right. You lose H, which is the acid, so you end up having metabolic alkalosis, and you lose your chloride with the H. So now you're hypochloremic. And renal compensation for this loss of H is by preserving protons at the expense of K. Right? So because you lost a lot of H in your vomit, the kidney is going to try to preserve H by throwing away K instead. So now you also become hypokalemic. As the disease is named, the red arrow in the image of the stomach is smooth muscle hypertrophy of the pyloric muscularis mucosa, forming the olive-shaped mass felt on palpation. This is a metabolic alkalosis because without chloride, the basolateral bicarbonate chloride exchanger in your PCT will not work. So you retain bicarbonate. Right? So you really want to make sure not only memorize, but also understand how this is supposed to be working. And that's basically what you're going to be looking for as your answer choices. And the good thing here was they told you the normals. Alright, so you know you're looking for hypochloremic, so all of the ones that have 90. Then you're looking for hypokalemic, you lost potassium also, so all of the ones that are less than 4, 3.2, 3.5, 3.2. Alright, so you're down to A and, well, just A actually now. Right, because once you do the hypokalemic, hypochloremic stuff, it's just A. And then you want to make sure everything else falls into place, right? So bicarb should be high because it's metabolic alkalosis, and it is high, 37. You're done. That's it. Sodium should not really have a massive change to it, and it doesn't. There's really, in answer choice A, it's 2 lower than normal, but it's, you can give that to the fact that the baby's vomiting or something, so it's not that big of a deal. 23. 2-year-old boy is brought to the physician because of increased thirst, urinary frequency, and failure to thrive. He appears frail. He's at the 5th percentile for length and 7th percentile for weight. Temperature is 100.4. Physical exam shows dehydration and decreased muscle tone. The diagnosis of Fanconi syndrome is made. Which of the following sets of changes in fractional reabsorption in the kidneys is most likely in this patient? So Fanconi is really easy. You just remember the PCT is not working. That's all Fanconi is. If your PCT is not working, you're not going to reabsorb anything because you practically reabsorb everything at your PCT. So what are you going to note? What is the question? Which of the following sets of changes in reabsorption? So everything should generally be decreased, and that's just answer choice H. Yeah, you're going to lose amino acids. You're definitely going to lose glucose. You lose phosphate, and you lose bicarb. Yep. And you can see this multiple ways actually in the book. So Fanconi is a PCT effect, right? PCT's job is to reabsorb everything, so you lose everything, right? Increased excretion of amino acid, glucose, bicarb, phosphate, and all substances reabsorbed by this PCT. That's what ends up happening. You lose everything. Everything that the PCT was supposed to absorb. What is your PCT supposed to absorb? Well, when you come up here, you kind of see that, right? Glucose, sodium, right? You're also going to be taking up your bicarb with your acetazolamide stopping it, right? Bicarb is another thing here. So your PCT is responsible for many things, reabsorption. We haven't gotten into renal yet in my newer videos, but the older videos already talked about it. So PCT does take back everything, and that's a really big issue if you have Fanconi. You lose everything. So that was all this question was about. Number 24. A hernia question, 3-month-old boy. So automatically, if you know if it's a hernia question because you kind of browsed at the answer choices, a 3-month-old boy, you should know what kind of hernia they're going to have, most likely. A 3-month-old boy is brought to the office by his mother because of a 1-week history of a lump on the right side of his groin. The mother says that when the patient cries, the bulge increases in size, and when he is quiet, it disappears. Physical exam shows a soft mass in the right groin region that decreases easily. Which of the following best describes the relationship of the hernia sac? So you look at all the answer choices, and B is the only one. This patient has an inguinal hernia. Inguinal hernias are usually reducible. Femoral hernias happen to females, and those are not reducible. This is an indirect inguinal hernia. It enters the internal inguinal ring lateral to the inferior epigastric vessel and is superior to your inguinal ligament, caused by a failure of processus vaginalis to close, and that's the one that's most common in male infants. Right? So lateral to the inferior epigastric artery and superior to the inguinal ligament. That part you already know. Both direct and indirect are kind of superior to the inguinal ligament. Femoral is inferior to the inguinal ligament. And if we go to page 401, we can take a quick look at that too. So diaphragmatic hernia is a whole different thing, and we had questions on diaphragmatic hernia as well in the same NBME. I think in one of yesterday's videos. The indirect, this is exactly what the kid is presenting with. This is how he looks. And when this kid is going to cry, this is going to get bigger. And when he's resting, it'll get smaller, stuff like that. Right? Maybe noticed in infants or discovered in childhood, much more common in males. An indirect inguinal hernia follows the path of the descent of the testes. Goes through the internal inguinal ring, external inguinal ring, and into the scrotum. Enters internal inguinal ring lateral to the inferior epigastric vessels, and is because the processus vaginalis did not close. So you can get a hydrocele. And if you look at that, that's basically like this, right? Indirect. Indirect goes into here. Direct is just a bulge like that, right? Inferior epigastric artery is right there. This is medial to it. So really important to make sure you know indirect inguinal hernia all the way in here. Right, everything. This is your intestines coming down in here, and every time he does some Valsalva type stuff, it's going to get bigger. Last one, 25, and then I don't know if I'll be able to keep going right now, but I might have to go pick up my mom. So either way, next time I come back live, I'll continue doing this and finish up block 3. Number 25, a 25-year-old primigravid woman at 42 weeks gestation is admitted to the hospital for failure to begin spontaneous labor. She has no history of major medical illness. Pregnancy has been uncomplicated. Her vital signs are within normal limits. Physical exam shows a uterus consistent with a 42-week gestation. IV infusion with oxytocin is initiated. Activation of which of the following signaling pathways most likely mediates the therapeutic effect of this drug for this patient? Alright, so remembering the signaling pathways takes time. The more times you revisit it, the better you'll get at it, but you also want to maybe have like sticky notes around you or something, or take a picture of it on your phone and look at it. It takes time, but you know what they gave her. So oxytocin is GQ related, and it uses IP3 and PIP2 lipids and increases intracellular calcium. It promotes uterine contraction and assists in milk letdown. First aid never discusses oxytocin in depth in one location, but it is discussed throughout the book. Alright, so this patient was given oxytocin, and that is going to be with D, phosphoninositide hydrolysis, which is a really fucked up way to put that answer choice there. But if you come to page 358 here, so signaling pathways, there's a lot you need to make sure you understand so that you can memorize them correctly. You got to know like little facts about all these things, and then it kind of, the more you know, the more networks you can create. So oxytocin is an IP3 thing right here, right? It's one of the GO tags. The only releasing hormone here are GnRH and TRH. TRH can upregulate prolactin release, so associate that with oxytocin, which is also here. But prolactin uses the non-receptor tyrosine kinase. So here, all the releasing hormones are in their own place, but here you have a couple weird guys. The IP3 one is a little weird because they're not all similar looking, but you have to remember it. IP3 is pretty much everything no one else wanted. So GnRH, TRH, your ADH and histamine, which already get discussed, but this is the V1 and H1 receptors. Right? The H2 and V2 receptors are both cyclic AMP. Cyclic AMP and GMP are the easiest ones to memorize. Intracellular stuff is also super easy to memorize. All the cholesterol derivatives, they're all going to be intracellular. Receptor tyrosine kinase is everything that needs to grow, right? So insulin and all these other growth factors. These are all things that need to grow. MAP kinase, think growth factors, right? Mitogen activated protein, serine threonine kinase. So you think of how like insulin is anabolic, so it makes you grow. But I used to have another statement here. Where'd it go? I used to have a statement saying you want to think of like you need a map to grow your colony or something like that, like in in many video games. So always remember the map and growing. That's receptor tyrosine kinase. The non-receptor guys are immunomodulators, so that uses the JAK-STAT pathway. And UWorld has images like this talking about different pathways. You want to make sure you don't really need to know them in depth, but understand what the main concept is that you can get questioned on. That's really all that's happening with these images. So I've talked about them already when we did endocrine. It was the last thing in endocrine before starting endocrine path. Last thing in endocrine physio. So this stuff takes a little time. You could print this page out for yourself and really spend time reading it. But you want to make sure each day that you memorize one of them perfectly. And then keep going on like that. Alright? So that's it for this. And the next time I come back live, I won't be live right now. So I'll probably continue either later tonight or tomorrow morning. Tomorrow morning at like 10. But either way, I don't know when I'll be live again because Friday and weekends are a little weird for me. But next time I am live, I will continue on from here. And the one that's definitely for sure is Monday at noon. I'll continue doing more NBME. So thanks a lot for joining. Keep studying hard, and I'll see you guys again later on.